Okay, well, we are going to get started. All the topics that Dr. Shell has asked me to cover, it's about impossible to cover it in 2 sessions. So I'm going to go very quickly, and these may go over by a few minutes. So as you saw my note on the board, just get up and go whenever you need to, and I won't be offended at all. So part 1, we're going to talk about uterine blood flow, maternal-fetal drug transfer, fetal heart rate monitoring, umbilical cord blood gas analysis, and then some more clinically related things like labor analgesia, non-obstetric surgery during pregnancy. So to put in a few questions to get you ready for the exam. So which of the following is most likely to decrease uterine blood flow? If anyone wants to answer, go ahead. If not, I'm going to tell you that the answer is the paracervical block. So first of all, in terms of uterine blood flow, the uterus is not capable of autoregulation. So your uterine perfusion is going to be dependent on 3 factors. Adequate driving pressure, which means your maternal blood pressure, low uterine venous pressure, and low uterine vascular resistance. So what this means is, in terms of the low uterine artery pressure, obviously, as I said, that's going to be maternal pressure. So if you have a hypotensive mother, that's going to decrease your uteroplacental perfusion. What about increased uterine venous pressure? Well, vena cava compression can lead to that. Contractions, especially uterine hypertonus. And this is why when you have a bad tracing, you might see the nurse turn off the Pitocin because they're concerned about uteroplacental perfusion. And the Valsalva maneuver during the 2nd stage of labor when someone is pushing can all increase your uterine venous pressure and therefore adversely affect uteroplacental perfusion and ultimately the fetus. And finally, increased uterine vascular resistance. That's a pretty easy one in terms of knowing that both endogenous and exogenous vasoconstrictors can affect uterine vascular resistance. So if mom's in horrible pain, it increases her catecholamine levels. Now, 1 to 200,000 epinephrine that is administered epidurally, not intravascularly, but epidurally, will not increase your uterine vascular resistance. High concentrations of local anesthetic can, and that's probably part of the reason why paracervical block has an effect on uteroplacental perfusion. And then certain disease processes that we commonly see in pregnancy, like preeclampsia and diabetes, can increase uterine vascular resistance. In terms of choice of vasopressor, how does that affect uteroplacental perfusion? Well, ephedrine has both alpha and beta effects. So compared to phenylephrine, there will actually be less of an increase in uterine vascular resistance. And that's why it was previously the vasopressor of choice in OB. But now phenylephrine is the vasopressor of choice, despite the fact that because of its alpha effect, it will increase your uterine vascular resistance more. The reason that it's now the vasopressor of choice is that it has been shown that the cord pH in infants whose moms had hypotension treated with phenylephrine is higher than the cord pH of moms babies whose moms were treated with ephedrine. This has nothing to do really with the uteroplacental perfusion. What it has to do with is placental transfer. There's significantly more placental transfer of ephedrine, and in the fetal effects, it's more of an increase in the fetal metabolism that leads to that increased, that decreased uterine artery pH or umbilical artery pH in babies whose moms were given ephedrine. So even though phenylephrine causes more increase in uterine vascular resistance, it is preferred because of the direct fetal effects of ephedrine. In terms of maternal-fetal drug transfer, various factors that will affect placental transfer include the concentration of the drug in the mother. So the higher the maternal concentration, the greater the placental transfer. The drug diffusion constant of a particular drug. So that's going to be determined by the molecular weight. So the lower the molecular weight of the drug, the smaller the drug, the greater the drug transfer to the fetus. The degree of protein binding, only the unbound part of a drug can cross the placenta, so drugs that have low protein binding are going to cross more easily than those that are highly protein bound. The lipid solubility, high lipid solubility will increase transfer, lipid solubility, the opposite. And then the degree of ionization. So only unionized drugs can cross over the placenta to the fetus also. And so the lower the degree of ionization of a drug, the greater the drug transfer. Other factors that are going to affect placental transfer include placental binding. Some drugs will bind within the placenta and thus won't be transferred to the fetus. The placenta is an active organ itself. It has metabolism going on, so some drugs will be more highly metabolized within the placenta itself and will not cross over. And then anything that alters your placental perfusion will affect your fetal drug transfer. So hypovolemia, aortal caval compression, those will actually decrease your transfer to the fetus. Not that you really want those things to happen, but when they do happen, there will be less drug transfer, as well as vasoconstrictors. Vasoconstrictors will affect drug transfer. Now, once the drugs get over to the fetal side, what affects the fetal drug concentration? So one is metabolism, and for some drugs, there are immature pathways that contribute to elevated drug levels. One example of this would be meperidine, and it's the reason why it's not commonly used in obstetrics anymore. And then fetal protein binding. The fetus generally will have lower protein binding capacity compared to the mother. So for those drugs that are highly protein bound, there's not as much transfer, but once those drugs get over to the fetal side, they are more likely to equilibrate with the maternal side because of the fact that there's less protein binding on the fetal side, and so there will be more free drug available on the fetal side. And then finally, fetal pH will have an effect on fetal drug concentrations within the fetus. And so this leads us to our next question. So a patient who's receiving epidural labor analgesia is taken to the OR for emergency C-section due to fetal bradycardia. Her epidural should be dosed with which local anesthetic? And so I would say the answer is 3% 2-chlorprocaine. And the reason for that is this idea of ion trapping. So local anesthetics, they cross the placenta to the fetal side. In an acidotic fetus, a greater percentage of that drug is now going to become ionized because of that acidotic environment. Once it's ionized, just like it can't cross over to the fetus, it also can't cross back over to through the placenta to the maternal side. And as a result, you get fetal accumulation of that drug and can get high drug levels. So most of our local anesthetics do pretty readily cross the placenta, like bupivacaine, ropivacaine. However, chlorprocaine is your drug of choice in the setting of fetal distress because of the fact that ion trapping is not an issue because of its short maternal half-life. It is metabolized so quickly on the maternal side that there's minimal drug transfer to the fetus. So even in an acidotic environment, you are not going to see drug accumulation of the local anesthetic on the fetal side as compared to your other local anesthetics where you will see ion trapping. So going on, talking about placental transfer, the least amount of placental transfer will occur with which of the following anesthetic drugs? So the answer would be succinylcholine, and this relates to the fact that your neuromuscular blocking agents are large molecules, and as you remember, we talked about the fact that molecular size is one factor that's going to affect drug transfer. And so drugs that don't cross the placenta in significant amounts, this has been on the exam in the past, are going to be your neuromuscular blocking drugs, as I said, due to the fact that they're large molecules, are also highly ionized. So you don't have to really worry about a muscle relaxant you give to mom affecting neonatal tone if a baby's delivered after mom's received the muscle relaxant. Other drugs that don't cross include heparin because it's a large molecule and it's water soluble rather than lipid soluble, and insulin also because it is such a large molecule. So those are some things to keep in mind in terms of what doesn't cross the placenta. Another question that's been asked on the ITE in the past has been related to the maternal-fetal distribution of bupivacaine. So because of both the high degree of maternal protein binding and the high pKa of bupivacaine, the transfer of the drug to the fetus is relatively limited. However, as I mentioned before, there's less fetal protein binding than maternal protein binding. So this leads to the fetal concentration of the free drug bupivacaine equilibrating with maternal concentration. So even though the total fetal concentration of bupivacaine will be less than the maternal concentration, the concentration of the active drug, the active unbound drug, will actually be equalized over time between the mother and the fetus. Another question that's been asked has been related to the placental transfer of anticholinergics. Things to remember is that this directly correlates with the ability to cross the blood-brain barrier. And so drugs that easily cross the blood-brain barrier, easy way to remember is they also easily cross the placenta. So for instance, if you give atropine to mom, it will cross and it can affect your fetal heart rate. Scopolamine also easily crosses. On the other hand, glycopyrrolate, because it's a quaternary drug, minimally crosses the placenta, and so it will not have a significant effect on fetal heart rate. So that's something to remember on the exam. Now, moving on from drug transfer to maternal fetal oxygen transport, placental oxygen transfer occurs via diffusion. So the transport is going to be determined by the difference in PaO2 between mom and the fetus. Some things to keep in mind that will help promote oxygen delivery from the maternal side to the fetal side include the Bohr effect. And this idea is that at the same time that you have maternal to fetal oxygen transfer going on, you also have fetal to maternal transfer of carbon dioxide, which will make the maternal blood more acidic and the fetal blood more alkalotic. This will lead to a right shift of the maternal hemoglobin, a maternal oxyhemoglobin dissociation curve, and a left shift of the fetal curve, and so this is going to favor unloading of oxygen to the fetus. One thing to remember when you're thinking about oxygen transport, anything that is going to help promote delivery of oxygen to the fetus is usually going to be going on. Also to remember though, fetal oxygenation, the fetal PO2 never reaches about higher than 50 to 60 millimeters of mercury. Part of this is because, as I said, the placenta is an active organ itself. It uses a large amount of oxygen. It has a high rate of oxygen consumption. In addition, fetal arterial blood is actually a mixture of oxygenated umbilical venous blood as well as deoxygenated blood from the inferior vena cava. Fetal hemoglobin and oxygen transport, other things to keep in mind. And I think this was one of the new keywords that Dr. Shell put on the list this year that I guess there must have been some sort of question last year on the exam. Fetal oxygenation depends both on the maternal fetal oxygen gradient, and another effect on fetal on oxygen transport relates to the different types of hemoglobin. So hemoglobin F, which is predominant in the fetus, has a greater affinity for oxygen and a lower affinity for 2,3-DPG. That results in a leftward shift of the oxyhemoglobin dissociation curve in the fetus compared to the mother, and that leads to a P50 that's lower in fetal blood compared to adult blood. And so the hemoglobin F and the higher hemoglobin concentration, as you know, babies, fetuses have significantly higher hemoglobins. The combination of those lead to fetal arterial oxygen concentration being really just minimally lower than adult arterial blood oxygen concentration, even though, as I mentioned, the baby is going to have a lower oxygen tension, the fetus. It's going to be, as I said, not higher than 50 to 60. What about effects of maternal PaO2 on fetal oxygenation? Well, at normal fetal PaO2, an increase in maternal FiO2 is going to have only a slight effect on fetal PaO2. However, when you have a fetus that is hypoxemic and probably acidotic, you will have an increase in maternal FiO2 can be significantly beneficial because you are now on the steep part of the fetal oxyhemoglobin dissociation curve. And so that is why when on labor and delivery they have a concerning tracing, they all of a sudden put oxygen on mom, because now they're on the steep part of the curve, and increasing maternal PaO2 may actually help with delivery of oxygen to a hypoxemic fetus. Now we're going to move on to fetal heart rate monitoring. So which statement about fetal heart rate patterns is most likely true? And so the answer would be that sustained fetal heart rate greater than 180 may be indicative of fetal hypoxia. So fetal tachycardia can be caused by many reasons, but one of those is fetal hypoxia. So when you're looking at fetal heart rate monitoring, and generally on the exam what you may see is a tracing, they're not going to just ask you, you know, it's a late decel, it's an early decel. You're going to need to know sort of what type of decel it is, what causes that, and probably what sort of management you need to do based on that type of tracing. So parameters monitored, it's sort of like an EKG. You need to be systematic. First you look at baseline fetal heart rate. Then you look at variability. Then you look at your periodic patterns, which is decels and exhales. And then in combination with that, you look at how those periodic patterns are associated with uterine activity. So first of all, in terms of baseline fetal heart rate, normal heart rate is anywhere from 110 to 120 to 160. Fetal tachycardia is greater than 160. Fetal bradycardia, less than 120, or oftentimes you'll have babies with relatively low baselines. Really, clinically significant fetal bradycardia is going to be less than 110. So, etiologies of fetal tachycardia, as I mentioned, it can be due to fetal asphyxia hypoxia due to inadequate uteroplacental perfusion. So that is why you get concerned when you see a fetal tachycardia. But you need to differentiate that from other reasons that would not mean that you necessarily need to proceed to delivery immediately. So if you have a mom who's febrile or septic, you can see not only a tachycardic mom, but a tachycardic baby, thyrotoxicosis, and various drugs. Maternal drugs that will increase maternal heart rate. Some of those can cross the placenta and significantly affect fetal heart rate. And so, as I mentioned earlier, atropine, but also large doses of ephedrine could affect fetal heart rate, as well as the beta mimetics that we give primarily for tocolysis, such as terbutaline. In terms of fetal bradycardia, the most concerning, most common reason for fetal bradycardia is acute fetal asphyxia and fetal acidosis. As I mentioned, though, you can see local anesthetic toxicity from a paracervical block. That's why we don't do those in OB patients, because there's a high rate of fetal bradycardia associated with them. Maternal beta blockers can decrease fetal heart rate, and there have been case reports of C-sections done as a result of fetal bradycardia after mom received a beta blocker. And then congenital heart block is another reason for bradycardia. Next, after you've looked at your baseline fetal heart rate, next you're going to look at your heart rate variability. And so this is going to look at primarily beat-to-beat variability. And this is actually the most sensitive indicator of fetal well-being if you have good short-term beat-to-beat variability. Long-term variability is another indicator of fetal well-being, but it's not as sensitive as the short-term. And this is just an example of what would be considered good fetal heart rate variability. Etiologies of decreased beat-to-beat variability. The reason it's such a sensitive indicator is that a common reason for decreased variability is fetal hypoxia and acidosis. That's what we get concerned about when we see a flat tracing. But we also have to realize there are other things that can also decrease that variability, including a fetus that's sleeping, and most importantly, several drugs that we as anesthesiologists may give to mom that can affect beat-to-beat variability, including opioids, including if you give a bolus dose of opioid through an epidural, barbiturates, your volatile anesthetics, benzodiazepines, anticholinergics. They can all decrease beat-to-beat variability. Then you want to look at your periodic patterns. So accelerations essentially are an increase in fetal heart rate of at least 15 beats per minute that occurs either with the fetus moving or when there's a uterine contraction. And then what we're most concerned about, though, are the decelerations early, which is defined by an onset and a peak of the deceleration that occurs during the contraction. Essentially, the decel mirrors the contraction, and you do not have a deep drop. You don't see heart rate dropping lower than about 100 beats per minute. Variable decelerations are, as they're described, they change from contraction to contraction in terms of shape, how long they last, how low they go, but they commonly will reach a heart rate that is less than 100 beats per minute. Whereas late decelerations, those first of all occur after the onset. Their onset is after the peak of the contraction. They don't return to baseline until after the contraction has ended. And just like early decelerations, they don't they are not generally deep. You usually will not see a drop in heart rate below 100 beats per minute with a late deceleration. So this is just an example of early decelerations, variable decelerations. As you can see, they look a little bit different with each contraction, and then late decelerations, where you can see, although subtle, that there is a drop and it doesn't return to baseline until after the contraction's over. So, as I said, you need to not just be able to identify them, but understand what do they mean. So early decelerations are generally felt to be a vagal reflex that results from head compression during contractions. They are not concerning. They don't require any sort of treatment. Variable decelerations are also a vagal response, and in the vast majority of cases, this results from umbilical cord compression. Although variable decels occurring very late in labor may also be due to intense dural stimulation as the fetal head gets compressed as it traverses the birth canal. Variable decelerations, if they are recurrent and deep, can be concerning because the baby's not having time to recover and can develop acidosis. If you have occasional variable decels that are short in duration, not deep, those are not concerning. And then finally, your late decelerations, these occur as a result of inadequate uteroplacental perfusion. So they are always bad. Even though they are not very large drops in fetal heart rate, they are bad. They're always concerning. And this is where you need to do some in utero resuscitation. So what you'll see is that they put oxygen on mom. They make sure she's has some left uterine displacement. May give a fluid bolus. Us as anesthesiologists, we need to check if we have an epidural. What's the blood pressure? Is she hypotensive? If so, then we need to treat aggressively, not only with fluids, but usually vasopressor. Then moving on to umbilical cord blood gases. So what finding on umbilical cord blood gas is most likely to be associated with an adverse neonatal outcome? And that is going to be the umbilical artery mixed acidemia. Thing to remember is the metabolic acidemia is what you're concerned about. A respiratory acidemia is not been associated with poor outcome for the neonate. And so this slide just shows you what are normal umbilical gases, artery and vein, and the umbilical artery is most important. That really is an indicator of fetal condition. Umbilical vein is more an indicator of maternal and placental condition. And so the types of acidemia, the way that you can differentiate them is by looking at your PCO2, your bicarb, and your base deficit. So a metabolic, as you imagine, you're going to have a low bicarb and a high base deficit, but a normal PCO2. The other one that you're concerned about is a mixed, where you do have a high PCO2 because you have a component of respiratory acidemia, but you also have a low bicarb and a high base deficit. Now, moving on to physiologic changes of pregnancy. So, when is the cardiac output of a parturient at its highest level? And that is going to be answer B, immediately postpartum. Other questions related to physiologic changes. Which of the following is most likely to represent an abnormal finding in a woman at 38 weeks gestation? And that is actually going to be a pulmonary artery pressure of 22. Central pressures should not be changed in pregnant women. So, talking about cardiovascular changes of pregnancy, cardiac output increases throughout pregnancy. By the third trimester, it's about 50% above pre-pregnancy levels. And this is due to a combination of primarily increase in stroke volume of about 30%, as well as about a 10 to 15% increase in heart rate. And that's just with the pregnant state. When you get into labor, you have further increases during the active stage of labor, another 30% increase. During the second stage, when she's pushing, she's really working, a 45% increase above pre-labor levels. And then in that immediate postpartum period where you have an autotransfusion, involution of the uterus, you see as much as an 80% increase in cardiac output beyond what was the 50% increase that occurred just due to pregnancy. Other cardiovascular changes, blood volume increases by about 35% due primarily to an increase in plasma volume. You see a decrease in SVR of about 20%, which can lead to a mild decrease in blood pressure. And then central pressures are unchanged as I mentioned in that question, due to the fact that although you have increased blood volume, you also have dilation of the vessels, so they sort of equal out. Moving on to some other questions. So which of the following is most likely to be decreased in a healthy parturient at 36 weeks? And that is going to be your creatinine levels. So moving on to some of the other systems. In terms of respiratory, minute ventilation increases up to 50% by the time you reach term, due primarily to a significant rise in tidal volume, although you will also see a small increase in respiratory rate. In terms of lung volumes and capacities, your expiratory residual volume and your residual volume are going to be decreased. You'll see a slight increase in your inspiratory reserve volume, and FRC decreases by about 20% in an upright pregnant woman due to those decreases in ERV and RV. When you lay her supine, and especially if you lay an obese woman supine, you'll see an even further decrease in functional residual capacity. Your vital capacity, though, your total lung capacity, those are unchanged in pregnancy. Oxygen consumption throughout pregnancy is increased significantly by about 20%. And again, during labor, as you can imagine, there's a reason it is called labor, and so it increases by about 100% during labor. Oxygen delivery, as I mentioned, pretty much anything that's going to optimize oxygen delivery to the baby is going to occur in a pregnant woman. So you have a right shift of the maternal oxyhemoglobin dissociation curve, facilitating oxygen delivery to the fetus. So looking at this, a normal arterial blood gas in a non-laboring parturient in the right upright position at 37 weeks gestation is most likely. And so the answer is going to be that because of that increased minute ventilation, you are going to see a decrease in your PaCO2, somewhere between 26 to 32, around 30. However, you will not see a marked respiratory alkalosis. Your pH is only going to be slightly increased, and that is because there is a metabolic compensation that occurs. You have a decrease in your serum bicarb level. So you will see a low PaCO2, a low bicarb, but a relatively normal pH. And you may see a small increase in your PaO2. Going on to gastrointestinal changes, there are hormonal changes that occur in pregnancy that affect the GI system. So you have an increase in progesterone during pregnancy that results in a reduced lower esophageal sphincter tone. You also have mechanical changes occurring in the GI system due to the cephalad displacement of the stomach. That leads to an increase in intergastric pressure, and it also distorts the GE junction, and that contributes to the gastric reflux that is common in pregnancy. So these clinical implications of these GI changes are that pregnant women are considered to be at an increased risk for aspiration. Hematologic changes, as I mentioned, blood volume is increased due primarily to plasma volume. You do see an increase in red cell mass, though. There is an overall increase in red cell mass, but you see a dilutional anemia due to the fact that you have a greater increase in plasma volume. And pregnancy is a hypercoagulable state. Pulmonary embolus is a leading cause of maternal mortality. That's been a question sometimes on boards. What are major causes of maternal mortality? In terms of CNS changes, the MAC of volatile anesthetics is decreased by about 30 to 40% in pregnancy. Local anesthetic requirements are also decreased. And in terms of the MAC of volatile anesthetics, the etiology of this seems to be related to things such as the increased endorphin and enkephalin levels, and women actually have been found to have an elevated pain threshold as a result of those increases in endorphin and enkephalin levels. Renal changes, you have an increase in your GFR, and as a result, your creatinine clearance is increased, so you should see a decrease in creatinine. A normal creatinine in pregnancy is going to be about 0.5 to 0.6. So if you have a preeclamptic patient with a creatinine of 1 or 1.1, if you looked at that in a non-pregnant patient, you'd say, oh, that's normal. That is not normal. That is a patient who's showing renal dysfunction as a result of her preeclampsia. So normal creatinine is going to be about 0.5 to 0.6. So moving on to tocolytics. This tends to be a topic some years they like to cover. What are the adverse effects of tocolytics? So The administration of terbutaline for the treatment of preterm labor is most likely associated with which of these following? And the answer is going to be actually fetal tachycardia. The drugs none of the tocolytic drugs have been shown to significantly extend pregnancy. Mostly they might help get you a couple of days in order to get things like steroids in for fetal lung maturation. Terbutaline actually will vasodilate. It can cause a drop in maternal blood pressure, and it can affect, you can see maternal hyperglycemia. So the effects of your beta-adrenergic agents, they decrease uterine activity. They do cause some vasodilation, but they do not have a significant effect on uterine blood flow. They, as you can know, can cause bronchodilation. They do cause release of ADH. The adverse effects that we can see with this, pulmonary edema is the most serious common adverse effect of beta-adrenergic agents. You can see maternal tachycardia, maternal hypotension, hyperglycemia, and especially so in diabetic patients. You can see hypokalemia. However, although you have hypokalemia, your total potassium content does not change. And so actually you probably don't want to treat that hypokalemia. There have been cases of hyperkalemia when you treated the hypokalemia induced by a beta-adrenergic agent. There is an increased risk of uterine atony if you've recently received a tocolytic beta-adrenergic drug. And as I mentioned, you can see fetal tachycardia. You can also see fetal hypoglycemia. Magnesium sulfate is another tocolytic drug that also decreases uterine activity. It does cause some vasodilation, does not significantly drop maternal blood pressure, and in preeclamptic patients, it's actually been shown because of that vasodilatory effect, it can help improve uterine blood flow. And in patients with preeclampsia, it is used for seizure prophylaxis. Adverse effects of magnesium, it can also include pulmonary edema, sedation. At levels higher than therapeutic levels, at toxic levels, you can first see respiratory depression, followed by respiratory arrest, and ultimately cardiac arrest. And then the other thing we need to understand is that magnesium does have an effect at the neuromuscular junction, so that you will see potentiation of both your depolarizing and non-depolarizing neuromuscular blocking drugs with the administration of MAG for either preeclampsia or preterm labor. Calcium channel blockers are probably the most common tocolytic being used now, primarily nifedipine. The reason for that is that it has very specific effects on the myometrium like the other drugs, but more importantly, it has less adverse effects in terms of cardiac and effects on serum electrolytes. So overall, there are less side effects from a calcium channel blocker nifedipine than a beta agonist or magnesium. That's why it is primarily the drug of choice. The most common side effect of nifedipine is hypotension. Rare but life-threatening are concerns about pulmonary edema and myocardial infarction. Very rare, and in terms of the pulmonary edema, less common than with your other tocolytic drugs. So now we're going to move on to labor analgesia. So a woman in active labor at 5 centimeters dilation is having pain with each contraction. Which of the following is most likely responsible for her pain? And it is going to be, during the active phase, it is going to be the passive stretching of the cervix. During the first stage, that is what causes the pain. When you get into the second stage of labor, the stretching of the perineum causes a somatic pain also. And then moving on to which of the following anesthetic techniques is least likely to provide adequate analgesia for the first stage of labor. That is going to be a pudendal block that will take care of the somatic pain in the second stage, whereas all the others will give you good analgesia for the first stage of labor, including paracervical block, but we don't do those because of the association with fetal bradycardia. Another question, when compared to IV opioids, epidural labor analgesia is most likely associated with which of the following? And the answer is going to be an increased incidence of maternal fever. There is an association between epidural and maternal fever. There is not a higher risk of C-section with labor epidurals. There is not a shorter duration of labor. Second stage of labor is prolonged by about 15 minutes. And depending on the study you look at, you may or may not see a 30 to 45-minute increase in the first stage of labor. And there are studies that have shown that women with epidurals generally need more augmentation with oxytocin. So labor analgesia, first stage of labor, you have visceral pain that's caused by that cervical dilation and distension of the lower uterine segment. The pain pathways for the uterus, the visceral afferents accompanied sympathetic nerves from T10 to L1. So for early first stage of labor, you need to have a block that extends from T10 to L1. Second stage of labor, you now also have somatic pain from the stretching of the perineum as the fetal head descends. The pain pathways for that are from the pudendal nerve, which are made up of from the S2 to S4 nerve roots. So in the second stage of labor, you now need a block that extends from T10 to S4 to get adequate analgesia. And this is just a nice little table to look at to see different types of regional analgesia and what they will cover and won't cover in terms of first versus second stage of labor. As I mentioned, paracervical block, although it does give first stage labor pain, we don't use it because of the risk of fetal bradycardia that is felt to be due to the high levels of local anesthetic. And also another thing to keep in mind with a paracervical block is it produces the highest maternal serum levels of local anesthetic among all the various regional techniques. Adverse effects of epidural will include hypotension. I already mentioned can be prolongation of the labor, increased maternal temperature. So that's a quick overview of labor analgesia. We could go on and on about adjuncts, etc., but we just don't have the time for that. Now moving on to non-obstetric surgery during pregnancy. So which of the following recommendations best reflects the ASA statement on non-obstetric surgery during pregnancy? And the answer would be is that if possible, surgery is best performed in the second trimester. If the baby's pre-viable, it is recommended that you still document fetal heart tones before surgery to make sure that you do have a viable fetus. If the fetus is viable, continuous intra-op fetal heart rate monitoring it can be helpful, but the statement does not say that it is necessary. And in fact, obstetricians oftentimes won't do it, and oftentimes the surgery is such that it's not possible to do it. Midazolam, it is considered as a benzodiazepine in the category D, but a one-time use of midazolam for anxiolysis sedation has not been associated with any sort of teratogenic effects. So in terms of non-obstetric surgery during pregnancy, special considerations are just like on the labor and delivery floor. If she comes to the main OR, you need to think about those physiologic changes of pregnancy and how that affects the mother. Concerns about the teratogenicity of drugs. And very important is making sure that throughout our anesthetic and surgery that we're maintaining uteroplacental perfusion and fetal oxygenation, and also strategies for preventing preterm labor, especially in surgeries that are higher risk for that, such as abdominal and pelvic surgeries. So in terms of teratogenicity of anesthetic drugs, the chronic use of Valium has been associated with fetal anomalies, at least in poorly controlled studies. And as a result, all benzodiazepines are classified as Class D drugs. Nitrous oxide really is controversial, although the data that has suggested possibility of teratogenicity or increased fetal loss miscarriages is very poor data. So my feeling is if it needs to be used, you can use it, but I wouldn't use it if not necessary. The reality is there's no specific technique or drug that has been shown to improve fetal outcome or to adversely affect fetal outcome more than other drugs. Regional anesthesia is often preferred because of the fact of the maternal risk associated with general. It also minimizes drug exposure to fetus, and as the idea about especially many of our general anesthetic drugs effects on the infant and the toddler. There's also concern about effects on the neonate, on the fetus also. And so another reason to prefer regional anesthesia so that we just don't deal with that issue. When you're doing non-obstetric surgery during pregnancy, remember if she's greater than 20 weeks, you can have some component of aortic cable compression, so left uterine displacement. You want to avoid maternal hypercapnia because that can lead to fetal acidosis, but you also want to avoid maternal hyperventilation because if mom becomes alkalotic, that can lead to uterine artery vasoconstriction, which will also affect oxygen delivery to the fetus. Remember when we talked about fetal heart rate tracings, drugs that we give for anesthesia can affect the fetal heart rate tracing. So if you do a continuous fetal heart rate monitoring during general anesthesia, your opioids, your induction agents, your inhalational agents will all decrease or even eliminate your variability. So really the only thing you can assess in a patient under general anesthesia if you're doing fetal monitoring is the baseline fetal heart rate and whether or not there are any decelerations. The incidence of preterm delivery is increased in patients undergoing surgery. Part of that is due to the fact that they have some underlying condition requiring surgery, but we do know that the greatest risk for preterm labor associated with non-obstetric surgery is surgery that's done during the 3rd trimester and surgery that's done in the pelvis or the abdomen. And in those patients, you may consider some prophylactic tocolysis. Finally, anesthesia for cerclage is another topic I was supposed to cover. So as most who've been on OB know, this is generally performed with neuraxial anesthesia, usually a spinal, because of concerns for the mom in terms of general anesthesia as well as avoiding drug exposure of the fetus. For a cerclage, you essentially need a T10 to S4 level. So they're working down around the perineum, so you want the sacral nerves to be blocked. However, when they start pulling on that cervix, remember the innervation of the uterus and the cervix is T10 to L1. So you want a block that goes T10 to S4. Generally, we avoid any sort of sedative or anxiolytic drugs because of those concerns about drug exposure of the fetus. And I don't know what the question was that put this as a key word. I don't know what else to say about anesthesia for cerclage other than that's what we do. They are generally less than 20 weeks gestation, so you shouldn't have to do any sort of left uterine displacement. And I got done in less than 45 minutes, so thank you.